and thanks for joining us for our Facebook Live today. We're discussing skeletal dysplasia. We're here with Dr. Belther, one of our physicians in our division of orthopedics, and Dr. Lindstrom, one of our physicians from our genetics department. So we'll just go ahead and jump right in. If you guys have any questions throughout the Facebook Live for either of our physicians today, please feel free to just type them down there and we'll make sure that they get answered for you. All right, so thank you both for joining us today. We really appreciate it. Our first question, can you please explain what is skeletal dysplasia?
So skeletal dysplasias are just a bone or cartilage condition that affects usually the shape or strength or size of the bone. And it can happen anywhere from when a baby is still in its mom's womb all the way up into even childhood or adulthood for its presentation.
Okay. Mm-hmm. Is it a genetic condition?
It can be. Okay. Some of the main causes of skeletal dysplasias are genetic, and there is testing available for a lot of those types. Also, things like infections or certain chemicals or toxins during pregnancy can sometimes cause dysplasias too. So not all causes are genetic, but many of them are.
Okay. And what are some symptoms? How would a parent know to bring their child in to get tested?
There's a lot of symptoms that can be early presenting symptoms. Sometimes it's the size or the stature, so if a child is particularly short, especially compared to their family expectation. Sometimes it's the shape of the bone, so you might see bowing or like an unusual shape to the limbs. Sometimes the bones are really fragile, so fractures can be an early presentation. And sometimes there can actually be asymmetry or a difference in size or even missing bones that may be the clue.
Okay.
And I think Dr. Belther had some.
Couple of others. So sometimes in the first trimester of pregnancy when they have an antenatal ultrasound at 20 weeks, 20 week scan, second trimester, then sometimes the length of the femur may be short, and then a few other things like that they could pick up in the ultrasound scan these days, and then that may be another clue that the child has something going on, and then the obstetrician would then sometimes make a prenatal consult. We do offer, like there's an Arizona fetal care network which is available. So if something like that happens to be picked up on the antenatal ultrasound, then the obstetricians will inform the parents, and having gotten their consent and getting them on board, then they could make a referral to get a prenatal consult, and that way the child is kind of plugged into the system as soon as we know about it.
Okay.
So,
is it more commonly diagnosed in utero, or does it just depend?
Both.
Okay.
So certain types are very highly suspected in utero because of the shape of the bones or the length of the bones, or maybe proportion of a skull size to a leg bone size. But there are other types that would have no signs early on and might not even show when the baby's born. You might not see it until they're 5 or 10 or 15. It sort of just depends on which type it is.
So not all skeletal dysplasias are diagnosed in the antenatal period, but some can be.
Okay.
And then the other thing is when they go to the pediatrician, like annually for the well-baby stroke clinic, they're going to check their height and weight and then plot it out on a growth chart. So if the child is off in terms of height, like not keeping completely like within 2 standard deviations, then that would be another clue for the pediatrician and then the family also to get to know that probably they may have some reason for not keeping in proportion in terms of growth of height, and then that may be another reason for referral.
Okay.
Yeah. And also if there's a family history of skeletal dysplasia, then again that they would probably, there could be higher incidence.
Some types of genetic skeletal dysplasia run in families, so sometimes the parent is already aware that they may have the same condition as the child, or they suspect that they do. And other times, even if it's genetic, the mutation or the gene change can actually happen in the child alone and not necessarily inherited from the parents. So it could be spontaneous, or it could also be something that's inherited and passed from generation to generation.
Okay, so that kind of sums up our next question, is what causes skeletal dysplasia. So if it's not genetic, is it just random
Some of the non-genetic causes can be things like, there's a few specific medications that are specifically not recommended for women to take in pregnancy because we know it can affect the bones. Gestational diabetes, which is very common, can sometimes affect the bones and cause forms of skeletal dysplasia or at least bone differences. Also, infection can sometimes do it. So those may not be known specific diagnoses, but they may be ultimately suspected to be the cause because of the way they look on X-ray or the rest of the child's medical history.
How is it diagnosed? If it's not in utero, is it just that their bones aren't a normal size for a well baby check, or?
There's probably three main components to the diagnosis, I think. There's the physical appearance, so the clinical exam that either the pediatrician or a more specialist person like Dr. Belfer or myself might notice, specific features. Then there's X-ray findings, which often help you get more to the particular diagnosis. So a skeletal dysplasia, we may suspect just by looking at a child on the outside, but until you really see what the bones look like, how they're formed, where are they different or how are they different, that's one of the biggest clues. And then genetic testing is sort of a newer addition to that, but something that's now becoming more and more common, especially to tell different kinds of skeletal dysplasias apart, because there are actually many kinds that can look somewhat similar in X-ray, but have different genetic causes.
And are they treated differently each form?
They can be, and that's something you could speak to a little bit more.
Well, in terms of treatment, you could mainly put them under two groups: medical treatment and surgical treatment. So and then like supportive or functional treatment. So the medical treatment, for some of them, there may be medications like the lysosomal storage disorders. For example, we have some enzyme replacement therapy. So that's an example, but not all skeletal dysplasias have medical treatments. Okay. There's always advances happening, but as of now, we don't have treatment for all skeletal dysplasias, but some of them have. So that's where endocrine and then genetics come in. For example, osteogenesis imperfecta, we have medications which won't cure the osteogenesis, but at least cure some of the effects of that. For example, making the bones stronger in osteogenesis, they have brittle bones, so the bisphosphonates or the palmitoronic treatment or some other kinds of treatment can make the bone stronger. So that kind of helps in the overall management of the child. So that's medical treatment. And also they may have other symptoms because it's usually affects multiple systems. So they may have issues with hearing, other systems which may need like treatment. And then surgical treatment would depend on, it could be orthopedic, neurosurgical, ear, nose, and throat, depending on what problem they have and which system is affected. So then you deal with that. And then the supportive treatment, obviously most children need to advance their activities of daily living and function. They will need physical therapy, occupational therapy, so some kind of rehab.
Okay. So a lot of times, especially when a child comes through genetics, we sort of act as the physician for the condition itself, because some of the conditions are a lot more than just skeleton. As Dr. Belfer was saying, they could affect the vision, the hearing, other aspects that you may not realize unless you knew a lot about the condition itself. So having sort of a multidisciplinary team or more than one kind of doctor involved is helpful, because Dr. Belfer may be focusing on specifically what can be done for the bones in terms of surgeries or strengthening or stabilization. But then I can also think about, well, what other organ systems should we be investigating for the child?
Okay, that's great. What should parents and patients expect in the long term for skeletal dysplasia?
Well, I think it depends. The natural history of each skeletal dysplasia is different, and in some of them we don't know. We're finding out as people find out and report more. So, for example, achondroplasia, I think they do pretty well in the long term. The prognosis is good for the most part, but they can have some issues, medical issues, which may come up as they grow, become a child and a young adult and adult. They may need some medical attention for various things.
And I think there's two big things that factor into how kids do overall and what parents should expect. One is the condition, with a specific condition. There are some that are very, very severe, and children may really have a lot of problems or even life-threatening issues early in infancy. other conditions which may not even appear until later in childhood and are much more mild or slowly progressive. But then even within any given condition, there's a spectrum. So there might be a milder version and a more severe version of that same condition.
Okay.
And it could be different for each family. So I think it's important for everyone to be thought of as an individual, to look at the needs of that child in context of what the condition is that they have, to sort of figure out what are the possible issues, and then what does that child have within that spectrum. So, some children, even with the same condition, may have a very different medical experience than others. Some may need surgery, some may not. Some may need a lot of frequent doctor's appointments, others really may not.
Okay, so it's more of an individualized approach.
Mm-hmm.
But I think earlier the diagnosis is done, the better, or at least for most of the conditions.
What if a child does not have a specific diagnosis, but the pediatrician or parent may suspect it?
I think there's a couple places right now that they could be referred to, although ultimately that's also what we're trying to address with a new clinic that is coming later this year, where a lot of the doctors who are involved in skeletal dysplasia will sort of be in one place together. But for now, if a pediatrician or a parent was suspicious of a skeletal dysplasia, depending on what the issue was that was making them suspect it, a referral to either an orthopedic physician like Dr. Belthor or a geneticist like myself might be reasonable to start.
Okay, and does it matter which one, ortho or genetics? Is it?
I think it probably depends in part about what kinds of issues the child is having. So if, either one of us will probably start with getting a lot of Xrays to sort of investigate further. But if the child's having active pain or fractures, you might even want to do both. And if a pediatrician has a specific patient in mind and they're trying to figure out what's the best, calling, to speak with a physician and do a consult over the phone just to sort of say, I have a 5-year-old who's experiencing this, where should I start? Sometimes we can guide them and say, well, it sounds like maybe you should get some X-rays and have them see ortho, and then if Dr. Belthor was suspicious of a dysplasia, he could send them to us, or vice versa if there wasn't active issues but just sort of short stature or something that made them curious.
And you sort of answered this one, touched on it a little. Dysplastic Children's have a program dedicated to skeletal dysplasia. It sounds like one is in the works, so can you tell us a little bit about it?
Yeah, I think we've been working the last few months to build a program. So I think we are getting together a group of physicians with a special interest in taking care of children with skeletal dysplasias and the support of their families. So we have Dr. Lindstrom from genetics, myself from orthopedics. We have Dr. Shahid from endocrinology. We have Dr. McClendon from neurosurgery, Dr. Milligan from ENT, and then we have Dr. Andrew Miller for anesthesia. So we are trying to assemble, I think it's Dr. Woodward for pulmonology. So we're trying to assemble the key players into the program, and then hopefully we aim to have at least one or more providers who have a special interest in taking care of the children as we build the program.
Okay, and it sounds like it's going to be a multidisciplinary approach to the care.
Mm-hmm.
Right.
Most of these patients end up having a lot of these physicians anyway that they see independently, but I think multidisciplinary care in general is thought to be a big plus for kids that need to see a lot of doctors, because not only can they kind of take one day or one half day to get a bunch of visits in, but then we can all talk to each other in real time, as opposed to, me seeing a patient who's not going to see Dr. Belthor for another 2 months. We can all sort of see them and chat about things and come up with probably faster and more comprehensive ultimate treatment plans for patients that take everything into account. And we can learn from each other too. There's things I've probably seen that others haven't, and things that others have seen that I've never. And so I think learning how another physician would manage a particular symptom will help me, when I'm dealing with patients, to sort of tell them what to expect, or to help guide, next steps for them as well.
Another thing I forgot, we have radiology on board as well, Dr.
Mm-hmm.
Okay, great.
So, and then we are also building relationships with Seattle Children's Hospital, and then the Skeletal Dysplasia bone health program there, and then in DuPont Hospital with Dr. McKenzie, who is the current, I think, chairman of the medical advisory board for LPA. So I did my training with him, and then Dr. Lindstrom did a training in CHOP, Philadelphia, Children's Hospital of Philadelphia. And then, so we can ask them for advice too if we have like cases that we cannot put our heads together, then we kind of ask them to help us out.
There's a lot of other clinics like this already in the country, and so we can learn a lot from how, what's worked well for them, how they set things up, and just sort of how they run to try to start, hit the ground with, a plan.
So in addition, we are both going to the LPA meeting in Denver, Colorado, where they're going to have some medical advisory board workshops as well as some symposia. So we're going to attend them to kind of learn more from other people or from other programs around the country, so we can kind of build a better program here.
That's great, and it sounds like summer is what we're shooting for when the program will be up and running.
Yeah, we're aiming to have our first clinic probably the end of July.
That's great, and I think it'll be great to have one place with all the providers so families don't have to come multiple days, multiple times. I think they'll really look forward to that, so that's great. And the multidisciplinary approach we already touched on. What can families expect during their first visit, either to this clinic or to either of you as it is now when they're referred for a potential diagnosis or a diagnosis of skeletal dysplasia?
One thing that probably all children will get, especially if they've never had this before, is a comprehensive set of X-rays. There's a type of X-ray called the skeletal survey, which basically looks at almost every bone in the body, and that's important for two reasons. One is that sometimes they provide diagnostic clues. So sometimes the appearance of a tiny bone in a finger can actually help us determine what type of skeletal dysplasia a child has. And it also gives us a sense of how involved it is for them. Do they, even if the child's not experiencing hip pain, do they have some bone problems in their hips that could cause an issue later? So a lot of times we will be doing full sets of X-rays on patients, whether they come to genetics or orthopedics or our combined clinic, so that we can really get a good sense of how the full extent of their skeletal involvement.
Okay, great.
So we are also planning to have like a multidisciplinary radiology conference, like a week before the clinic every month.
Okay.
So we will have most of the key providers and the radiology people there, so that we view the X-rays as a group, and then they have
So you're
put our heads
prepared
together.
before the family.
Right, so that we kind of have a game plan as we're seeing that patient that day about what are the issues that we may want to focus on or address.
That's great. Right. And will your team communicate with the patient's pediatrician? So if, after the clinic or after an appointment as it is now, will you relay that information so it's sort of the circle of care for the families?
Yeah, the pediatricians, who are often the referring providers to these types of clinics, but regardless, the referring provider and the pediatrician would get an electronic or a fax copy of our notes. And we'll probably each have a separate note from each provider so that we can make sure that they sort of understand the plan as it goes from each discipline.
Okay, that's great. All right. Does Phoenix Children's partner with any community organizations or offer any support services for families with skeletal dysplasia?
The LPA, the Little People's Association, that's the main group who actually sort of inspired this clinic to get off the ground, and they've been a huge support, a huge resource of information, and also of guidance, I think, in how we're going to form the clinic. We're really taking their input and their recommendations into account to make sure that we're meeting their needs. So they're a community group. It's a countrywide group, but we have a community, we have a local chapter, and they've been, really helpful in this whole process.
Three other groups. Osteogenesis has an OI foundation, again, national and world level group, but I think we have some representation locally, but we need to kind of make it stronger to help support families with diagnosis of osteogenesis imperfecta or other bone health related problems. Same thing, lysosomal storage disorders. I think genetics has a big group of patients that they follow both in CRS clinic as well as here.
Okay.
So I think they already have a support group in place, right? Or if not,
There's a few specific, sort of a little niche even within skeletal dysplasias of children that have them because of a lysosomal problem or a specific enzyme problem that affects the bones. And a lot of those specific conditions have a big network also locally as well as throughout the country for their particular conditions as well.
And the other thing, we are also partnering with Raising Special Kids.
Okay.
Because all these kids are special, so they're going to be our community partner to help us help these children, because they're plugged into all the other activities and special activities and other resources that the families need. So we are working closely with them, not just for skeletal dysplasia, also for other children, but they will be helping with this clinic and with this population as well.
Okay, great. All right, is there anything else that we didn't touch on that you want to make sure our families tuning in hear about, or anything else about the clinic?
So, like I said, the Arizona Fetal Care Network, they are going to be plugged into the system as well. So obstetricians and families will have access to them. They have a central coordinator, and then they can send referrals to them. In addition, we do outreach clinics in Flagstaff. This clinic won't be there in Flagstaff, but for patients in northern Arizona, we could see them there, and then we could feed them into this clinic if they want to be seen by the whole group. But like from our group, orthopedics, we go out there once a month.
Okay.
Like 3 of us, but then I go out there, but we can feed them, bring them back into the system here. We did have a clinic in Yuma, but I don't think we don't have any provider going there at present, but those are the things.
Okay, and what's the best way for families to make an appointment? Should they schedule to their pediatrician? Should they call our centers directly?
I think orthopedics has a scheduling number. It's 602-933-3033.
Perfect.
But we'll have kind of more details as the program. They probably will have access to a nurse coordinator, and that's how they'll be able to schedule into the clinic.
But patients don't have to wait. I mean, if there's a concern right now of a patient out there who they think might have a skeletal dysplasia, they can be referred to genetics or orthopedics specifically, and we can always pull them into that big clinic if and when the time comes, if it's appropriate for them. So no one should wait. If they're concerned, they should just reach out. And if there's any significant concern, a pediatrician can always call and ask for advice on the best way to get a child in which clinic and in what timeline is appropriate.
Great. Well, thank you both for joining us today. We appreciate it. If you guys have any other questions, please feel free to leave them in the comment section, and we'll make sure that they get them.